Step 2 CK Final Sprint, Outpatient and Follow-up. Let's get right into it.
You're evaluating an acutely ill diabetic patient admitted with sepsis and acute renal failure. Their home meds, metformin, low-dose aspirin, and atorvastatin. So what's the most appropriate next step in managing their diabetes? Discontinue those oral meds and start basal bolus insulin. The big clue here is the acute renal failure and sepsis. You see, metformin carries a real risk of lactic acidosis, so it's absolutely contraindicated when creatinine is elevated or during a severe acute illness. Now, you might be tempted to just continue the home regimen to keep things stable. That's the trap. But that only flips to the correct answer if the patient is a completely stable outpatient with normal kidney function.
Okay, next case. A diabetic patient with a history of cardiovascular disease presents for follow-up. They're on an SGLT2 inhibitor. Today, their labs show an eGFR of 28. What's the best medication adjustment? Discontinue the SGLT2 inhibitor. Why? Because that eGFR dropped below 30. SGLT2 inhibitors are amazing for reducing cardiovascular morbidity, sure, but they are contraindicated with impaired renal function at this level. Don't fall into the trap of continuing the med just for its heart failure benefits. You only do that if the patient's eGFR is sitting comfortably above 45.
Moving on, we've got a young type 1 diabetic presenting with early morning hyperglycemia, currently on a standard insulin regimen. What's the best next step? Measure nocturnal blood glucose levels. You've got to do this to differentiate the dawn phenomenon, which is just a normal physiologic morning growth hormone surge, from the Somogyi effect, which is actually rebound hyperglycemia caused by nighttime hypoglycemia. The trap here is the reflex to immediately bump up their evening long-acting insulin. You can only safely make that adjustment after you've definitively ruled out nocturnal hypoglycemia. Here's one. A 35-year-old never smoker has an incidental finding of a smooth 0.6 centimeter solitary pulmonary nodule on a chest x-ray done for a mild cough. What's the next step? No further testing. The clue? This patient has a super low risk profile. They're under 40, have no smoking history, and the nodule is smooth and smaller than 0.8 centimeters. The trap would be recommending surgical excision or a biopsy here. You only go down that road if the patient is high risk, say over 60 and actively smoking, with a nodule showing a corona radiata or a spiculated margin on imaging.
An asymptomatic 72-year-old comes in for a routine checkup. Labs show a TSH of 8.5 with a normal free T4. Best next step? Routine monitoring. Notice the clues. They're over 70, completely asymptomatic, and the TSH is only mildly elevated, somewhere between 7 and 9.9. Starting levothyroxine is the trap here. You'd only initiate hormone replacement if that TSH was above 10, or if this elderly patient actually had convincing hypothyroid symptoms, like a rapidly enlarging goiter.
Now, an ICU patient recovering from severe sepsis is noted to have a low T3, normal T4, and normal TSH on a standard lab panel. What's the best next step? Monitor without treatment. Context is everything for this one. A severe acute illness causes euthyroid 6 syndrome, which is just a transient state to minimize maladaptive catabolism. Don't jump into the trap of treating for central hypothyroidism with hormone replacement. That's only indicated if these abnormal thyroid functions persist long after the patient has completely returned to their baseline health.
A stable patient with bipolar disorder, well controlled on lithium, presents for a 6-month follow-up. What is the most appropriate monitoring test to order today? TSH monitoring. Keep in mind about 25% of patients on lithium will develop hypothyroidism, so they need TSH checks every 6 to 12 months. The classic distractor trap here is ordering an ECG. You only need an ECG for baseline studies before starting lithium in a patient who already has known coronary risk factors.
A patient with rheumatoid arthritis and prolonged morning stiffness is getting ready to start methotrexate. What's the best initial screening step before they begin? Tests for hepatitis B and C. Methotrexate carries a real risk of hepatotoxicity, so you absolutely have to ensure there's no underlying liver disease before starting it. Another common trap is skipping folate supplementation, which leads to stomatitis and macrocytic anemia. The flip is to always concurrently administer folic acid because it mitigates the toxicity without reducing the drug's effectiveness. Next up, a patient with rheumatoid arthritis has been on hydroxychloroquine for 5 years with really good symptom control. What's the best next step in their routine management? An annual ophthalmologic evaluation. Long-term hydroxychloroquine use has a risk of retinopathy. Guidelines say you need baseline screening, followed by annual reassessments that kick in right after that 5-year mark. Checking for demyelination or congestive heart failure is the trap here. But that would be the exact right next step if they were taking a TNF inhibitor, like infliximab or etanercept. A hyperthyroid patient taking methimazole presents to the clinic with a sudden fever and a severe sore throat. What's the best next step? Stop the drug immediately and check a CBC. That combination of fever and sore throat while on an antithyroid drug is a massive red flag for agranulocytosis. The trap is reassuring the patient that it's probably just a viral URI. You can only safely offer that reassurance if they've already stopped the drug, their white blood cell counts are confirmed totally normal, and there are absolutely no signs of toxicity.
A new patient comes to your clinic requesting refills for chronic opioid therapy originally prescribed by a previous doctor. Best initial step before writing that prescription? Query the Prescription Drug Monitoring Program database and perform a urine drug screen. Strict risk screening is a hard requirement before starting or continuing chronic opioids. Do not fall for the trap of simply refilling it right away just to prevent withdrawal. You can only authorize that refill once all safety agreements, a one prescriber and one pharmacy designation, and baseline screenings are fully documented. A completely asymptomatic patient comes in for a routine physical. Labs show an isolated, mild neutropenia, but the rest of the CBC is perfectly normal. Best next step? Calculate the absolute neutrophil count and repeat the CBC. The key clue here is that this is an isolated finding in an otherwise totally well patient. The trap is immediately referring them for a bone marrow biopsy. That is overkill. You reserve that invasive step for patients with a severe ANC, splenomegaly, active symptoms of infection, or other concerning cytopenia. All right, a 55-year-old active smoker presents with unexplained microscopic hematuria on a routine urinalysis. No evidence of glomerular disease or UTI. What's the preferred next step? Flexible cystoscopy. You've got microscopic hematuria combined with a huge risk factor for bladder cancer, smoking. The trap is just repeating the urinalysis in a month to see if it clears up. Observation is only the right answer if there was evidence of an active UTI or if it was gross hematuria linked to a glomerular disease you're already managing. A 45-year-old patient is found to have asymptomatic primary hyperparathyroidism. Their serum calcium is 1.2 milligrams per deciliter above the upper limit of normal. Next step, parathyroidectomy. The clues here are the age, under 50, and the calcium elevation being greater than 1 milligram per deciliter above normal. Those are hard, explicit indications for surgery. Routine observation and fluid hydration is the trap. That only becomes the right path if the patient was over 50, didn't have complications like osteoporosis or kidney disease, and had a borderline calcium level less than 1 milligram above normal. A patient presents with spells of severe headache, profuse sweating, and sudden hypertension. What's the best initial diagnostic test? 24-hour urine fractionated metanephrines and catecholamines, or plasma fractionated metanephrines? When your suspicion for a pheochromocytoma is high, you have to start with biochemical testing. An immediate CT or MRI of the abdomen is a really tempting shortcut trap, but it's wrong. You only move to imaging after those metanephrines are confirmed to be 2 to 3 times the upper limit of normal. A 30-year-old woman with a 10-year history of oral contraceptive use has an incidental solid liver mass on an ultrasound. Most likely diagnosis and next step? Hepatic adenoma, and you must discontinue those oral contraceptives. That 10-year OCP history is the classic risk factor for these adenomas, which carry a real risk of hemorrhage or turning malignant. The trap is diagnosing focal nodular hyperplasia. That only flips to correct if the imaging explicitly describes anomalous arterial flow and a central scar. A patient tells you they just can't afford the newly prescribed brand name medication for their chronic condition and they're really stressed about their health. Best counseling response? Recommend prescribing a generic drug alternative. As physicians, we have to provide the greatest benefit at the least expense when we're collaborating on health goals. The trap is simply discontinuing the therapy because they can't afford it. Stopping treatment altogether is only the right answer if the medication is deemed completely clinically unnecessary. A healthcare worker presents with frequent, overtly dramatic symptoms that just don't match the clinical findings. Their motivation seems driven by internal factors. They want to assume the sick role, not get financial compensation. Diagnostic confirmation step? Direct observation or medical record review. This clinical picture screams factitious disorder, which requires discovering intentional falsification without an external reward. Starting cognitive behavioral therapy for somatic symptom disorder is the trap. That would be correct only if the patient genuinely believed they were ill, had high anxiety about it, and wasn't intentionally faking anything. A highly anxious patient comes back to your clinic for tissue biopsy results. The results are completely benign. Most appropriate initial statement? Deliver the negative results immediately as good news. When you're ruling out a serious illness, prolonging a patient's anxiety helps absolutely no one. The trap is building up to the result with a long, drawn-out clinical preamble to explain the pathology. Save that formal Breaking Bad news protocol for when the results are actually malignant.
A patient is diagnosed with a 6 mm ureteral stone. They have intact oral hydration, well-controlled pain, and stable vitals, correct disposition, outpatient management with an alpha blocker, pain control, and instructions to strain their urine. Because they're stable and the stone is between 5 and 10 millimeters, it can usually pass with medical expulsive therapy. Inpatient admission is the trap. It's too aggressive here. But it becomes the right answer if the patient develops intractable vomiting, anuria, acute kidney injury, or if the stone is larger than 10 millimeters and needs an urgent urology consult. A 25-year-old presents with 3 days of fever, abdominal pain, and mucoid diarrhea after eating undercooked poultry. Best management? Supportive care. Campylobacter gastroenteritis is typically self-limited and resolves on its own in under 7 days. The trap is immediately prescribing antibiotics. You should only prescribe those if the patient is pregnant, immunocompromised, elderly, or experiencing severe symptoms that last well over a week.
A well-appearing 5-year-old boy presents with a limp. He's afebrile, has a normal white count, and ultrasound shows a unilateral hip effusion. He is able to bear weight. Next step, conservative management. This child is well-appearing and bearing weight, which points straight to transient synovitis. The trap is urgent joint drainage and antibiotics. That invasive path is only correct if the child is ill-appearing, non-weight-bearing, and meets the Kocher criteria for septic arthritis, like a fever over 38.5 Celsius, a white count over 12,000, and an ESR over 40. A child presents with right lower quadrant pain. They have a history of recent sick contacts and complain of profuse mucoid diarrhea. Most likely diagnosis, infectious ileocechitis, which is often called pseudoappendicitis. The profuse mucoid diarrhea and sick contacts point away from a surgical abdomen. The trap is diagnosing acute appendicitis. You'd only pivot to appendicitis if the patient had severe right lower quadrant rebound tenderness, leukocytosis, anorexia, and definitely lacked that profuse diarrhea. Let's finish up with a 60-second final mental checklist for outpatient management. Ready? Always check for stable vitals first. Then rapidly run through renal function, pregnancy status, and age. Check the medication list for interactions or required monitoring tests. Assess the time to benefit and any adherence barriers like health literacy or cost. And remember, return precautions and safe follow-up are absolutely critical. Often on this exam, the correct answer is not to do more right now, but simply to monitor correctly.